Well, welcome everyone to our January online patient forum. This month we have Dr. Michael-John Devlin, who is a consultant in medical oncologist based at St. Bartholomew's Hospital, where he treats patients diagnosed with gynaecological and skin malignancies. Today, he will be talking about clinical trials and ovarian cancer. I'll pass you over now to you, MJ.
Thank you very much, Maria. Good afternoon, everyone. So, as Maria said, I'm one of the gynae oncology consultants in Bart's Hospital. I'm going to talk about ovarian cancer trials over the last few years and where we're sort of looking towards in the future. But what I would like you to get from today is maybe some appreciation on what clinical trials are about and what's a good trial, maybe what's not a good trial. So if you're seeing things in the newspaper, then you maybe have a little bit more of an insight. EAM's brief background on ovarian cancer and clinical trials, the evolution of treatment, particularly of high-grade serous and endometrial ovarian cancers over the last few years, recent advances in less common epithelial ovarian cancers, ongoing or planned studies, and looking to the future. So when we talk about ovarian cancer, we're talking about lots of different types of cancer. And sort of broadly speaking, there's three groups. So there's germ cell and sex cord stromal tumors, and they're less common than epithelial ovarian cancers, which will be the focus of today's talk. And within that sort of subgroup of epithelial ovarian cancers, there's lots of different subtypes or histologies. The other thing about ovarian cancer that's a little bit different to other types of cancers is how we stage things. So whilst things like lung cancer, they might talk about TNM staging, so the tumor size, the nodes, and if there's metastatic disease. In ovarian and gynaecological malignancies, we use something called the FIGO staging, and it goes from FIGO 1, which is where the tumor is confined to the ovaries, to FIGO 4, where the cancer is sort of distant, so far away from the ovaries. And stage 2 and 3 represents the creep between those two stages. And there are also lots of different types of clinical trials. So there's things like observational studies or interventional studies. And sort of an observational study might be you have a group of patients with a virus and you want to follow them over the course of 10, 15 years to see if they develop a certain type of cancer, but you're not doing anything to them other than observing. Whereas interventional studies, you're doing something different to some or all of the patients. And the thing that we're focusing in on these are these trials where we give investigational products or new types of drugs. And in terms of phases, there's 4 phases to clinical trials. So 1 is you have a new drug and you want to make sure it's safe and what the dose is that is safe. Phase 2 is when you identify whether the drug at the safe dose demonstrates any evidence of activity. So is there a hint that it might work for a certain type of cancer? Phase 3 is where you give that drug to lots more people and see, does it work better or the same as or worse than the current standard of care treatment, assuming that is one. And then stage 4 is after the drug's licensed and it's following patients up in sort of larger numbers. And each of those phases, the numbers of patients increase. So phase 1, you'll have, you'll count them in the low tens. Phase 2 will be more, phase 3 or much more. And most of the talks or studies that I'll be talking about today are phase 3. So they're where they've been compared against the standard of care treatment. And phase 3 are the types of studies that generally need to happen for us to license a new drug, particularly within the UK. And clinical trials are really important. And these 2 graphs, the first one is from 1996, and it's comparing what the standard of care treatment was back then which was cisplatin and cyclophosphamide, and comparing it to cisplatin and paclitaxel. And then the other graph on the right hand of the screen, the one that's in colour, is one from 2019, and it's looking at a PARP inhibitor in patients with high-grade serous ovarian cancer. So there's 23 years of difference between the two trials. And as you can see, if we look at 36 months, if we go along the bottom axis and go to 36, that's about 3 years, and we go over to the sort of percentage of patients that are surviving to 3 years, there's significant differences. And that is being driven by an improved understanding of biomarkers. So I've put things like BRCA in brackets there, but also drugs. We've got lots of new drugs now compared to what we did 2 decades ago. And these are all things that have come out of clinical trials. And in terms of trials over time in ovarian cancer, really there's been quite a flurry of activity from 2016, 2017 onwards. And a lot of the sort of new drugs, initially things like olaparib and bevacizumab, they were introduced in the first sort of after your cancer had come back maybe once or twice. And as we got to appreciate their efficacy or how well they worked in ovarian cancer, then we started to maybe bring them forward, and we're like, well, actually, we see that they're working quite well at this time point. Would they maybe work better if we give them earlier and earlier? And that's kind of what we see around here in 2019, where a lot of these drugs are now being given sort of as a maintenance after your first line treatment. And when we're thinking about treatment for ovarian cancer, the things that we consider are surgery and systemic treatment. And a lot of that will be guided on the stage of the ovarian cancer and also how fit the patient is. But there's lots of other factors like histology, the genomics, what the patient's symptoms are, their fertility status, comorbidities, which is another word for other medical problems. And ultimately what the patient choice is. So if it's an early stage ovarian cancer, then it tends to be surgery and systemic treatment on its own, or chemotherapy on its own. For advanced stage, it tends to be surgery, systemic treatment, and then some maintenance treatment. But we consider all of these things, and it's bespoke to the patient. Prior to 2019, there were sort of two main patterns for patients with advanced ovarian cancer. So they would either have upfront surgery and then move on to have 6 cycles of chemotherapy and fall into 3-monthly follow-up. Or sometimes they would have some chemotherapy upfront to shrink down the size of the cancer to make an operation possible. And then after the operation, they would have some more chemotherapy, and then they would enter follow-up. There were some select populations that would occasionally be given bevacizumab, but they were very much in the minority. Then now we have sort of 4 different lines of maintenance treatment that patients will feed into. And that's what we're going to talk about. How did we get from this point to this point? And one of the big things is biomarkers. So we're understanding the disease better. And I'm going to be talking about sort of DNA and genes. And within each of us, there's billions of cells. And within the cells, there's chromosomes. And those chromosomes contain DNA. And segments of DNA are called genes. And DNA is constantly under attack by lots of things, by, things like radiation, as we get older. And then there's lots of different ways in which we can repair damage to our DNA. This is a really busy slide, and we don't really need to think about most of it. What we're going to focus on is single strand breaks. So there's like 2 strands to DNA, one's shown in purple and one's shown in green. And if there's a break to one of those strands, then it's generally repaired by base excisional repair, so BER. If both strands are broken, there's a few different mechanisms that we can use to fix that, but homologous recombination, or HR, is the most is the one that will work best, is more likely to give sort of a good result. And why this is relevant in ovarian cancer is, in high-grade serous ovarian cancer, is that over 50% of patients will have a deficiency in homologous recombination. So they will have an altered ability to fix double-stranded breaks. And about 20% of those will be due to mutations in BRCA, which you may or may not have heard of. But there are lots of other genes that can be part of this homologous recombination pathway, and they can be deficient in ovarian cancer as well. Sort of why does PARP inhibitors and BRCA, how does this all sort of fit together? So if you have a single strand break and it's not fixed, it becomes a double-stranded break. And if that's not fixed, then the cell will die. And PARP is part of that base excisional repair pathway that helps fix single-strand DNA breaks. BRCA helps fix double-stranded DNA breaks as part of the homologous recombination pathway. So that pathway that works really well. But there are other pathways that can fix double-stranded breaks, but they don't work as well, and they're more prone to making errors that can result in cell death. So if you have a cancer that has a mutation in BRCA, this homologous recombination pathway just doesn't work. So all of those double-stranded breaks have to be repaired through the more mutagenic process, or the one that doesn't work as well and is more likely to result in cell death. So with a PARP inhibitor, if we block the activity of PARP, then we have many, many more single-stranded breaks that aren't being fixed, and they're progressing to double-stranded breaks. They are being repaired by the more mutagenic pathway, and that's resulting in cell death. And this is sort of how PARP inhibitors work in ovarian cancer. So how do we identify which patients are going to benefit from PARP inhibitors? So for patients that have a BRCA1 or BRCA2 mutation, we can either check their blood to see if this is a gene that they were born with. So is it a germline mutation? And we also check the tumor to see, is this something that's happened within the tumor itself as part of the process of becoming cancer? And the vast majority of patients, it'll be germline, so this will be a mutation that they will have been born with. But occasionally we do see patients where they don't have a mutation that they're born with, but it is evident when we look at the tumor. But this other group, it's a bit more difficult to sort of look for those. We'd have to check lots and lots and lots of individual genes, which isn't very practical. So what we look for is the effect of impaired homologous recombination on the tumor. And there are different sort of assays or different tests that we can do to see, is the genome scarred? Is the repair mechanism working ineffectively to the point where the DNA over time is being damaged and sort of half fixed, but not fixed properly? And therefore, when we look back in time, we might be able to identify that. And an analogy that I sometimes think of is that you mightn't be able to necessarily see Bigfoot, but you could find his footprints. So you might find evidence of homologous recombination deficiency, even if you never identify what the cause is or what the gene is. And sorry, this population, sort of all of them with altered homologous recombination, we'll call these GIS positive, or the genomic instability score positive. So moving on to the clinical trials with all of that sort of information, we're going to work through it sort of with the clinical trials. So SOLO-1 used the PARP inhibitor olaparib in patients with high-grade serous and endometrioid ovarian cancer that had a BRCA mutation. So that sort of 20% that we had in the top corner. And what they found was that there was a significant improvement in sort of the length of time that patients were living without their cancer coming back again when they took olaparib versus not taking anything at all. So if we move along the bottom of the graph again, so that's the months since randomization, so months since the trial started, and we go to 3 years. For the red line, which is the placebo tablet, and then we compare that to the olaparib tablet, we can see that there's a significant increase in the percentage of patients that are alive and disease-free who take olaparib compared to placebo. And this will be for patients with a BRCA1 or BRCA2 mutation. PAOLA-1 had a slightly different approach. So they used olaparib in combination with bevacizumab, which is a drug that targets cancer cells' ability to sort of create blood vessels around it. So if you reduce that ability, then you sort of make it more difficult for them to get nutrients and more difficult for them to grow. And they included patients regardless of their BRCA mutation status or their sort of gene instability score. And what they found was that patients with a positive gene instability score did significantly better with olaparib plus bevacizumab. So the ones that didn't have a positive score, so the ones where, you know, they didn't have BRCA or they didn't have a gene instability score that was positive, they didn't benefit from this treatment, whereas this population did. And then niraparib was used in PRIMA, and they had a similar approach. So patients were enrolled regardless of whether they had a BRCA mutation or their gene instability score. And sometimes if you look at papers, you'll see tables like this. And basically, this side shows things that do better with niraparib. And then this side of the line shows things that do better with the placebo. And if any of the lines cross the central line, it means that the result is not significant. So for example, this one, it's on the side of niraparib and it doesn't cross the central line. So that means that that population does better with niraparib. Whereas this crosses the line, which means that that population does not do any significant, there's no significant benefit to niraparib over placebo. And in patients that had deficient homologous recombination, they did better with a PARP inhibitor, which we're not surprised about. We would expect them to. But the thing that was interesting with PRIMA was that patients that were homologous recombination proficient, so that ability to repair the double-stranded breaks in DNA, that was still working. When we give them niraparib, they actually did better than placebo. So that's this population in purple that we've kind of been ignoring up to this point. They do better with niraparib than placebo, but also homologous recombination deficient do better with niraparib. So essentially all patients will derive a benefit from niraparib. If you have the gene instability score, you do better with olaparib and bevacizumab. So that's another option. They could have niraparib or they could have olaparib and bevacizumab. And then for that subgroup of BRCA mutant, they also could have olaparib. So if that sort of, if you're going to have maintenance treatment, you can have a PARP inhibitor of some sort. Moving on from high-grade serous ovarian cancer to less common forms of epithelial ovarian cancer. So in the red, so we've done high-grade serous at the top. We're going to move down to low-grade serous. Within it, its mutations are more different to high-grade ovarian cancer, and they often have mutations in this pathway called RAS-RAF. And LOGS was a study that took a MEK inhibitor called trametinib and compared that to the standard of care treatment. And how this drug works is it sort of targets a piece of the machinery within that RAS-RAF pathway, and that cancers that have a deficiency in the pathway are more likely to die from this targeted therapy than those without it. And we found that there was an improvement in progression-free survival. So patients that took trametinib versus, say, chemotherapy or hormone therapy, their cancer stayed away for longer. And moving on from this, so this was a trametinib, a drug on its own. There are other studies like RAM 301, which is about to open, I think, and that's looking at this drug in combination with another drug in this population. Clear cell, so clear cell does not respond to chemotherapy in the same way as other types of ovarian cancer, but there is encouraging signs that it does respond to immunotherapy. And one of the trials that was led out of Barts was the Peacock clinical trial, which gave pembrolizumab in clear cell ovarian cancer. And this was in clear cell where the cancer had come back after sort of first line treatment and surgery and chemotherapy. And we found that actually the response rates were 25% and around 60% of patients, the disease was controlled. And again, there's ongoing research into understanding why some patients respond and some patients don't, and how we can turn the non-responders into responders. And on the back of this, there's lots of other clinical trials sort of are about to open, looking at immunotherapy in clear cell ovarian cancer, but in combination with other drugs. So we know that pembrolizumab works on its own and it works quite well, but we think that if we combine it with another type of drug, then we should be able to improve the response rates. So similar to the low grade, we know that one drug works well. We think that we can make it work better by combining it with something else. And then for rarer types of ovarian cancer, things like your carcinosarcomas, your small cell ovarian cancers, the incidence of these are quite rare. So trying to get a phase 3 study is very difficult because the patient numbers would take many, many, many years to recruit. And sometimes these types of trials fail. So a different approach would be a basket trials where they're all included together as a cohort, rather than trying to sort of single them out all individually. And what Bouquet does is it takes all of these rare pathologies, and then it will look at the mutations within the cancer, and it's broken sort of down into 4 groups, where one is a no specific mutation, and then the others are common mutations found in these types of ovarian cancer. And it matches them up to drugs that we know from other studies are likely to give a clinical benefit to the patient. And it's sort of, again, a more personalized approach to treatment. And alongside this, there are studies like RANGO, which looks at rare neoplasms of gynaecological origin. And its drive is to improve our biobanking, or our collection of samples from patients with rare cancers, so that we have more resources to improve our research in these areas, because it's very difficult to do research if we, don't have samples or to do that on. And equally, if something's extremely rare, you're unlikely to get enough numbers from 1 or 2 centres. It needs to be a national or oftentimes international effort for sort of sample collection. And this is important for translational research, and this is taken from Genomics England, and if you go on their website, this actually moves and looks much more impressive. But it's the idea that translational research and clinical trials and sort of patient care go hand in hand. So with clinical trials, we're part of the process is taking samples that we can use in the lab to try and understand what works, what doesn't work. And then that will influence subsequent sort of treatment options that will go back into the clinic or into the clinical trials, where we'll then collect more samples, analyze them, get more information, and as time goes on, both sides will improve. So our understanding, the research side improves, and as a consequence of that, the options that we can offer patients also improve. So it benefits everyone. In terms of new approaches, drug antibody conjugates are in use in other types of cancer and are coming to the forefront in epithelial ovarian cancer now. What you have is an antibody which targets cancer cells, and attached to that you have a cytotoxic drug or a drug that targets cancer cells, and they're linked together by this sort of linker, which is shown here in green. And a good antibody is something that is expressed on cancer cells or minimally or not expressed at all on the normal tissue, so that when you get this drug, it's very selective in what it targets. And mirvetuximab targets folate receptor alpha, which is often expressed on the surface of epithelial ovarian cancers. And there was a very encouraging positive trial that came out late last year, and this drug is actually FDA approved at the moment. There are also trials looking at mirvetuximab in combination with other drugs. We know that this drug works quite well. We think that by combining it with something, we can make it work even better. And we can also use things like cytokines. So interleukin-2 can stimulate either Tregs or CD8 T cells. Basically, Tregs are kind of the pacifists of the immune system oftentimes. So they'll go to an area where there's a lot of inflammation and just calm everybody down. Whereas the CD8 and the NK cells are the ones that get quite angry, and they're the ones that will be more likely to target cancer cells. But the IL-2 that we have within our body normally tends to bind to the Tregs in preference. So it tends to bind to those cells that will, calm down inflammation, and that can be pro-cancer, so that can promote an environment in which cancer cells are more likely to grow. But we have new sort of artificial equivalents of interleukin-2 that will actually bind in preference to the CD8 and the NK cells, so the ones that are more likely to target our cancer cells. And there are clinical trials at the moment looking at that in combination with pembrolizumab, so with other immunotherapies in platinum-resistant ovarian cancer. So just to finish up, I'm revisiting some slides that I started with, and looking at how far we've come really in the last 2 decades. And that has been because of our understanding of biomarkers and new drugs, and an appreciation of sort of the biology of the disease that comes out of translational research, so that we understand that it's not just high-grade serous ovarian cancer. It's actually, whether they're GIST positive, BRCA positive, if they're homologous recombination proficient. And when we understand that, then we can sort of make the treatments much more personalized and much more bespoke to the patient, because everyone is unique, and everyone's cancer is unique. And moving into the future, our approaches are going to be unique as well. And I think we're starting to see that emerge, certainly over the last few years. Thank you. Is there any questions?
I have just a generic question.
Yeah.
If in terms of availability of these trials, do you advertise these to people across all of the country, or is it just Bart's patients? I just sometimes get asked from younger women that are suffering with gynae cancers about trial access at Bart's, and I just wondered if you publicize these trials for recruitment from other centres.
Yeah, so that's a really good question. So the trials will be sort of promoted on websites like the ECMC, There are also resources like clinicaltrials.gov where you can search for the type of cancer you have, or if there's a drug that you're a little bit interested in, you can search by that, and you can by center. Sorry, I threw my camera on as well. The other thing is, if you speak to your oncologist, we all sort of, particularly within gynae, we all know each other at a national level, and we all talk, and we all want the best for our patients. So if we, for example, if I had a patient who I didn't have a good trial option for, I would be looking around at other centres and be in communication with them to see if there's something else out there that would benefit them. So I think that the onus should not always be on the patient to have to find these things. So yes, there is the tools that they can use, but also they shouldn't be afraid to speak to their oncologist about it, because it's a partnership, and ultimately we all want the best treatment, and if that's not within your centre, sometimes we'll help them to a different centre, and vice versa. It works two ways.
Thank you very much.
Does anyone else have any questions?
I have one question. I hope I pronounce it correctly. So you mentioned about an anti-drug conjugated called mirtuximab. Am I correct? That you did say that this is something that is being approved in the US because it works quite well. Would this treatment be approved in the UK? Is there going through the review? What are your thoughts?
I think there's a phase 3 study planned with mirtuximab. So with the US, they can approve slightly easier and earlier than the UK. So oftentimes, if you have a really positive phase 2 study, so one of the earlier stages in clinical trials, that's enough evidence that in America you can approve. But in the UK, we tend to like a little bit more evidence, so that tends to be a phase 3 study. And we're also there are sort of set rules and that we follow in the UK to make sure, because of NICE and things, that when we fund a drug, that the evidence is of a good standard, but also what we're paying for the drug is a fair price as well. So all of those things take a little bit more time than America.
Thank you. Any more questions?
Yeah, can you hear me? Sorry, I'm not very good at unmuting.
Yes, hi.
Sorry, I was just going to ask, because my mother died, we're talking like nearly 40 years ago now, of ovarian cancer. And at the time, we talked about the difficulty in detecting ovarian cancer. So I'm wondering, is that still the case? Because the charts you show, that's sort of remarkable improvements, but is it still, are you still hampered by the detection levels, or has that improved as well?
Yeah, so that's a really good question. So in certain aspects, yes. In certain aspects, no. So we are getting better at identifying patients who are at an increased risk of having ovarian cancer. So if you carry one of those BRCA mutations, then we know that in your lifetime, you are at an increased risk of developing things like ovarian and breast cancer. And those patients are screened quite closely. And they're also oftentimes offered a prophylactic operation to remove their ovaries, the fallopian tube, and the womb once their family's completed. So in that sort of population, we've done better. In terms of the general population, there's a lot of interest in looking at different biomarkers or different things that we can check in the blood, but there's been no one thing that's been found that has been a game changer. I suspect that will change within the next 5 years. But as it currently stands, there's not a sort of something that's changed how we approach it at the moment.
Thanks.
And Joan, I think, did you have your hand up?
I did have my hand up. Sorry, I've almost lost my voice. But I think you just answered my question.
Okay.
So, I have a daughter-in-law, and she found a lump when she was 32. And she's had a double mastectomy, and she has the BRCA gene. So she's now coming up 39. So next year, they want to take her ovaries away, which is what you've just said. So I think really you just answered that question. Obviously, we worry about her all the time in the background, not to her. She just gets on with life, so everything's good. But it is a concern. On the other hand, I also have a sister who's 77, and she had ovarian cancer when she was 12 years old, and she survived that. She had an operation, and obviously she had radium treatment afterwards, as it was called then, and her I can't think of the name of it. All her system for reproductive system, sorry, obviously was non-existent after that. But she is still alive, and she's had no repercussions since, which is quite astounding considering it was, I don't know, 60-something years ago. And that, so obviously the worry is with Katie, and then once that's done, is the survival rate for those people with that have had their double mastectomies and their ovaries out, does that then put them back where everybody else is? Oh, it does.
Yeah, so I think that they will enter, you know, they'll still remain under surveillance, because the sort of the two big things that we look out for are breast and ovary. But if you sort of reduce the risk of that happening and they don't have cancer, the fact that you carry a BRCA mutation in and of itself does not shorten your life. The thing that would shorten it is if you developed a cancer because of that. So there's steps that we take, like sort of doing the risk reduction surgery, and monitoring these people. But carrying the gene in and of itself won't shorten your life. It's the cancer, and it's monitoring for that and treating it. That will be helpful.
I suppose what I was asking is, once obviously there's an attachment to the breast and the ovaries, but then beyond that, is there nothing then? Are you not likely to get it anywhere else? That's what I meant.
So there are other areas where you have an increased risk of developing cancer, but that does not mean it's 100% risk, and it's about reducing it down. So the things that, as I said, that we would worry about are the breast and the ovaries. There are other areas that you can get cancer, but that's generally covered by the surveillance team and then the genetics team.
But that is directly from the BRCA gene, is it? That's what I meant.
Yeah.
Okay. All right. Thank you.
Thank you. Are there any more questions? No?
Thank you all for giving me the opportunity to talk today. And if there are any other questions, I'm sure if you sort of reach out to Maria, she can pass them on to me and we can answer.
Thank you very much. I think we really enjoyed your presentation, and we've all learned quite a lot about this type of cancer. So thank you very much.
No problem. See you later.
Thank you.
Thank you. Goodbye.
Thank you. Oh, sorry, I was muted. I was going to announce the next meeting, but everyone's left, I think.
We'll still have people.
The next meeting is going to be on February the 28th, at the same time, I believe, and it's with Dr. Lucy Flanders, who is talking all about esophageal cancer, so like food pipe cancers. That should be also very interesting.
Thank you.
Thanks,
Bye-bye.
everyone.